Welcome, everybody, to the next episode of the Raja Anil FASD Book Club. It's all based on this book about prevention, recognition, and management of fetal alcohol spectrum disorders. We are having just quick bite-sized chats with the various authors of chapters in that book. So today we're joined by the two Alexes from the National FASD Clinic who are going to talk with us about the role of formal psychometric assessment in fetal alcohol spectrum disorder. And they're going to tell you what that is, because that's not necessarily something that rolls off my tongue. I don't know about yours. So if you don't mind, both introducing yourselves, because you'll do it better than I can, and then lead us through the discussion.
Thanks, Sandra. Yeah, hi, I'm Alex Carlisle. I'm a clinical psychologist and neurodevelopmental specialist clinician and FASD clinic lead. And the other, Alex, is...
Hello, I am Alex Livesey. So I am also a clinical psychologist. I also work in the FASD clinic, and I am the person that generally does the neuropsychological assessments within the team.
Great. So I'm going to share my screen now. And yeah, this is just as Sandra said, a very brief summary of the chapter and sort of pulling out some key points from it. Will hopefully become clear as we go through what formal psychometric assessment means. I'm trying to move my screen on. Here we go. So this is the FASD clinic website, and you can find more information about us from this website. And essentially what we're going to pick out to discuss today is where psychometric assessment fits into the SIGN criteria, what's the difference between direct and indirect assessments, look at some subtleties of presentation and interpretation in the time we have, but we'll maybe discuss more of that later, and look at a case study and yeah, have some time for discussion. So SIGN criteria. These have been adopted by NICE, National Institute of Clinical Excellence. So this is why I'm presenting them. This is the criteria that we work on in the clinic. As you can see at the top here is an algorithm for diagnosis. The first sort of rung, the first level is prenatal alcohol exposure. So there would need to be some evidence or some significant risk that there had been prenatal alcohol exposure. The next kind of rung on this algorithm is facial features. I know it's all quite small, but hopefully you can see that on your screens. So the presence or absence of a number of facial features, all three or less than three. The sort of diagnosis of facial features, as you might know, is based on all three being present. And then the next rung down on this algorithm is the central nervous system criteria, CNS. I'm going to refer to that going through. So when I say CNS, it stands for central nervous system. And another way of thinking about that is brain areas. And I'll go through what that means. And then after sort of considering those three areas in terms of SIGN guidance, then you'd come out with sort of FASD with or without facial features, or no diagnosis, or at risk. So hopefully this isn't totally new to people, but just thought I'd highlight that this is the process for assessment, and within that process, formal psychometric assessment generally takes place within the CNS criteria part of it. So that's what we're looking at when we're thinking about whether or not somebody meets criteria for FASD. We're looking at those different layers. And within the CNS layers, we think about these domains based on, again, SIGN guidance. There's only three needed to meet criteria for FASD. In order to meet the criteria or not, we would use formal psychometric assessments for some of them. And as you'll see in a moment, there are other ways, there are sort of direct and indirect ways of assessing these domains. But for many of these domains, it's possible to use formal psychometric assessment. And what I mean by psychometric assessment is a standardized tool. And we'll go into more detail about what that means in a moment. So I won't go through these in detail, but it's just picking out a few. It's very common to use a psychometric assessment for the area of cognition. For example, you wouldn't be able to diagnose or look at cognition without a formal psychometric assessment. There may be, for example, ways of using assessment within executive functioning that includes psychometric assessment as well, but there might be other different ways of looking at that, and we'll have a look at what that means in a moment. So this is just another way of kind of summarizing the central nervous system domains. And sometimes people are kind of confused about how the central nervous system domains fit in with other diagnosis, because often when you're assessing the domains, you do get enough information, if you've got enough information from the attention and executive function domain, that would indicate diagnostic criteria met for another condition such as ADHD. So this is how I sort of see them as fitting together, that the central nervous system domains are kind of like the panels of the umbrella, and the kind of tips of the umbrella is like where you might have enough information. Let's pick, just as I say, picking out between attention and executive functioning, you might have enough information that ADHD criteria met, or you might have enough information from assessing the domains to see that ASD criteria met. But within all of those potential possibilities, and they're not a given, like not everybody would have ASD or ADHD, and not everybody would have every domain met. It's only 3 or more to meet criteria, but there are these potential outcomes, and I won't dwell on that too much because that's not what we're talking about today, but just to see where formal assessment fits within that process. So summarizing the sign criteria, growth and facial features are things that can be looked at, and growth particularly used to be in the older guidelines. Facial features are still considered as part of sign guidance, but whether you have the facial features or not isn't sort of doesn't determine whether or not you have FASD. It's FASD with or without facial features, which means that the kind of core criteria of FASD involve central nervous system domains. So the formal psychometric assessment part of the assessment is important because it relates to the central nervous system deficits, which are, they have to be present in all cases of FASD, as well as obviously prenatal alcohol exposure, unless you have facial features, all 3 facial features, in which case the evidence of alcohol is slightly different. You may be able to give a diagnosis for somebody if you ruled out other factors, if there are facial features plus central nervous system deficits. So essentially, there's no single measure that I can sort of say to you, this is how you'd use and do an assessment, and it would always be the same. And there's no pattern of sort of outcomes with any particular measure. I can't say it would always look like this particular profile with an FASD. And that's because, it's not surprising, I should say, because of the potential differences in dose and timing of alcohol exposure, and the potential differences in genetics and other environmental influences. It means that there really isn't any single profile. However, we do sort of use formal psychometric assessments in there's direct and indirect assessment. So we can see that there are profiles and there are cut-off criteria that we use. So this is an example of direct assessments. The WAIS and the WISC are cognitive assessments. The RAY is a memory assessment. The CALF, the TALC, and the SCAN are language assessments. The DKEFs, the BADS, and the BADC are executive function assessment. I'm so sorry about all these acronyms. If you're a psychologist, you will know what that means. And if not, if you type it into Google, they will come up, I'm sure. But essentially, they're just an example of types of assessment that we use in clinic. They're not the only assessments that you could use. Also, we're really aware as a specialist clinic that we are in a privileged position to be able to use sort of formal direct assessments. And not everybody has access to psychologists who can, or speech and language therapists who can undertake these assessments. And within the sign guidance, there is the opportunity to do indirect assessments based on, and I haven't got time to go through the different domains, but for example, the cognitive domain, you would have to do a direct assessment. using the whisk or the waist, depending on the age of the child or the individual. But there are other domains that you could use either indirect or direct, and you need to look at the sign guidance for those. And we use both because we want to have a wider assessment anyway. I'll talk about that in a second. We use indirect and direct. And there's an example here of the kind of indirect assessments that we use. They may still be based on standardized tools, so they may still have a psychometric component to them. So an indirect assessment would be something like a questionnaire or standardized measure. So on the bottom arrow here, you've got indirect assessments, and an example would be something like a Conners questionnaire. You have a standardized measure, or a brief questionnaire, which is an executive function questionnaire. Conners is an ADHD questionnaire. Or it wouldn't necessarily have to be from the sign guidance a standardized tool. It could be the clinical criteria such as DSM-5, definition of ADHD criteria, if those criteria had been met. And then the direct measure, so both indirect and direct measures can be considered psychometric assessments, but it can get a bit confusing because often when people are talking about direct measures, when people talk about psychometrics, they're talking about direct measures. They can be both, but direct measures are often recognized in the sign guidance, particularly as sort of the ideal standard, but sometimes people don't have access to them. And there are reasons why sometimes, as it said here in bold, why actually indirect assessment would be beneficial, especially for executive functioning assessment. The definition of what impairment is in a direct assessment would be 2 standard deviations below the mean, or a major discrepancy between 2 scores, where the lowest score is at least 1 standard deviation below the mean. And a major discrepancy is, it only happens in less than 3% of the population. And there are tables that you look at to check whether it meets those criteria. What do I mean by standard deviation? Very briefly, this is a normal curve. It sort of spreads generally as a population. We're kind of spread it somewhere along this curve. If about 68% of us would have a cognition somewhere in that darker blue area. And sort of 0.1% of the population would have a cognitive ability of 145 or above. I did assess somebody once, a little boy who met that criteria, and it was astonishing. But generally, we don't run into people with those kind of extremes. Most of us fit between that sort of 68%. And then the 2 standard deviations below would be score of 70 or below. And that's about 2.1% of the population would have a score of 2 standard deviations or more below the mean. And it's this arbitrary cutoff. It's a long-standing neuropsychological cutoff for the definition of impairment, but it's that arbitrary cutoff that is used within the sign guidance. So when we use a direct measure, such as a cognitive assessment or a speech and language assessment, like the CALF, or an executive functioning tool, we're looking at scores that are 2 standard deviations or more below the mean to meet the sign criteria for evidence of impairment.
Alex, can I just quickly butt in there? If what you may come across as well is scale scores, standard scores, percentile scores, Z scores even sometimes, and ultimately, they're all measuring the same thing. It's a way of creating a raw score, which could be anything, could be, between 1 and 100, could be between 1 and 1,000. But it's a way of transforming a raw score from a test or a questionnaire into a standard score, which means you can compare it to the typical population, the general population. So if we're referring to, Alex has said, 68% of approximately 68% of people are within the sort of average range. That's 68% of a typical population, which whoever the test has been what they call normed against. So an IQ assessment, for example, the whisk and the waist, you've taken you hope, and we know with whisk and waist it's been tested on hundreds and thousands of people, so they can get a really good approximation of what an average score would look like. but it is, it is confusing sometimes to see these different categories of scores and know what each equivalent means. But psychologists will generally talk about standard scores, percentile scores, sometimes scaled scores.
Yes, we haven't got time to go into scale scores and standard scores, but there is a difference between scale score and a standard score. So the average of a standard score is 100 and the average of a scale score is 10. So but essentially a scale score usually is a subtest, and a standard score is a major composite or a major subdomain, an index or something like that. But this is all, I understand, sort of for most people, kind of totally new information. But if you see an IQ, so when I say cognitive, I mean the domain, the cognitive domain within those other 10 domains. Sometimes central nervous system deficits get labeled as the cognitive domain, but actually when I'm talking about cognition, I'm talking about just that one cognitive domain alongside executive functioning and attention and other domains that we talked about earlier. So specifically thinking about the cognitive domain, an example of that sort of how standard deviations would look. So 70 is 2 standard deviations below the mean, 85 is 1 standard deviation below the mean, 100 is average, 0 standard deviations, and then 115 is 1 above, 130 is 2 above. Moving slightly to the side, just sort of irrespective of what somebody's score is, it's important to be aware of how it might change over time. There is generally in the typical population, there is a sort of consistency you would normally expect, that if you score at sort of one thing at one age, that would be fairly consistent and predictable. However, within FASD, we know there's beginning to be more and more evidence that it actually widens this gap between sort of time 1 and time 2, particularly if you're assessing younger childhood. There's still more evidence that we need to collect on that, but that's what we see anecdotally, and there is some sort of international data that seems to support that. So just bearing this in mind is important in FASD, because in terms of access to support in adulthood, it might be that somebody's cognitive domain, but maybe even other domains also start off sort of more within the normal range and then might go to may potentially, not always, but may potentially differ more compared to typical sort of average populations. In terms of, I'm just aware of the time. So in terms of I'm coming to the end of my bit, in terms of interpretive considerations, if you find after assessing all the different domains that you possibly can assess, and it's understood that you can't always assess all 10 domains and you can't necessarily always assess them with direct tools, you might need to use indirect assessments. And that might be better sometimes to use indirect assessments as well. Even if you have assessed some domains in their average, it's not a sort of contraindication of FASD. You can have children with normal average IQ and have FASD. And it's often the adaptive functioning that can be impaired. And I think it's something that potentially other professions do struggle with. They might expect to see more of a deficit within the cognitive domain, or maybe find that individuals' adaptive functioning is reported to be different than their cognition, and people struggle to, maybe that's sort of an unusual presentation that's not typical in the population, and professionals really can have difficulty seeing why somebody can have an average IQ. That's why we consider the wider assessment. So direct assessment, this sort of lighter blue on the top right box here, the neuropsychological assessment or formal psychometric assessment, you might say, or direct assessment. It's only one part of an assessment, so we consider it alongside indirect assessment that includes these other factors. I'm going to hand over to Alex now.
Thank you. I'm actually, Alex, just going to skip over this one because you talked about this, which is just, the really important thing about triangulating lots of sources of information. So I think, again, people think a neuropsychological assessment is a child or an adult sitting with a clinician in a room doing tests, and that's just not the case. It's much wider than that. It is the formal assessment, but it is also observation within that setting. But it's also so important to get observation in different settings, in different structures, different environments, different interviews, reports from third parties. How is a child doing in school? How do they do in their extracurricular clubs? How are they behaving, presenting at home? I just wanted to really spend a little bit of time looking at this. So as Alex touched on, you can have what we call a full-scale IQ. So it's your sort of overall ability level that falls in average. And the picture on the left in all blue, someone that's all 5 of their indexes. So this is a WISC. This will be the children's assessment, are within average. But actually, that's highly unlikely in our experience within our clinic. What is more likely is you might still have an overall average full-scale IQ, but a real spiky profile of strengths and difficulties. So the pink is just showing below average and green above. So this particular person, has perhaps a real difficulty, relative weakness in verbal comprehension, but a real strength in fluid reasoning. Well, the way that full-scale IQ can work is that it basically can minimize strengths and flatten out strengths and difficulties, because essentially it makes it an average. It takes all those 5 different indexes and creates an average. So you can see, if you just reported the full scale IQ for this middle person, it wouldn't be a really good reflection of their true abilities. Similarly, what you can see is someone who has a full-scale IQ that perhaps is below average, but they've got a real strength in a particular area. And yes, this is unusual, but this comes also back to Alex's point that you don't have to have just an IQ below 70 in order to meet criteria for FASD. So this middle person, for example, may well have meet criteria if their verbal comprehension is below 70. It's possible that they would also meet criteria for a cognitive evidence of a cognitive impairment. So yeah, when you're interpreting particularly WISC and WACEs, which is what you will see for IQ, generally you might come across some other things like educational psychologists use things like the British Ability Scales. So there are a few more out there that are used in sort of education settings, but in clinical settings, WISC and WACE, it's really important not just to take the full scale overall cognitive score as a reflection of someone's abilities. Alex, do you want to skip on to the next one?
Can I just do a little time check here, because we do want to leave a little bit of time for questions if we can.
Yeah. So I'm not going to go away. I think this, everyone will have access to this as a recording, but I just put this up as a kind of a case study. It's not a real case study. It's an amalgamation of many hundreds of people, but it's quite a typical presentation of why it's so important to do a psychometric assessment. So this young man went through primary school, secondary school. Primary school was good, secondary school wasn't so good. There's some red flags if you read the detail as to kind of why there might be something going on intellectually, cognitively, some relative strengths and weaknesses, and it just it's a really good snapshot of, again, why we should be doing these assessments. And perhaps why, sometimes a couple of these assessments earlier on in childhood and later on. So because I'm aware of time, shall we stop there and go to questions?
Thanks, Alex.
Yeah, thank you both very much. I know this is a kind of an impossible thing to ask people to cover in 15 minutes time, and you've done really well. And judging by the questions, there's been, some interesting thoughts raised.